Ben Doktor Tuğba Uyar.
I'm working in Kashgar State Hospital in my compulsory service. I've been working for 2 years in Rize. I'm a neurologist and actually most of the neurological and also psychiatric presentations can be confused, and I'm very happy to be here as well. I'm working a half an hour distance to Acute Disease Hospital, Acute. In neurocognitive and neuropsychological effects, it has a certain effect. I feel very lucky because I am working in a region with lots of people because of genetic predisposition. Neurocognitive functions are very high, and their literacy levels are very high. So very easily I can communicate with them, and I can see the psychiatric presentations and neurological defects can be differentiated easily. The nerve and endocrine systems are working holistically. The nerve system is more target specific and gives rapid responses and short term. Endocrine systems are have larger effect, and it's effective on multi organs, endocrine glands. If we are to give a summary, hypothyroid, thyroid, parathyroid, adrenal, and pineal glands, the thymus, pancreas, ovarians, the stomach, liver, and also small intestines working together. So, in a thyroid, the depression actually specifically affects the mood. However, in endocrine system, we see multi-specific organ involvements. You see, I'll explain the hypothalamus, hypophyse, and thyroid axis. Thyroids are having a large space, and as stimuli decreases in hypothalamus, the hypophyse is formed, and then in the brain system, T4 secretion is there, and in the body, the thyroid, thyroxine, and thyroidectin hormones are there is an orexin system which we know, and this orexin system is the neuroprotective peptide, and it has an effect on our affected, and has effective on arousal system and our body composition. So it ensures our energy balance, and it is effective in narcolepsy and with thymogenesis. Has an effect on our BMI. The thyroid hormones, the neurocognitive effects actually are effective on dopamine, serotonin, and noradrenaline, and dopamine concentration, motivation, and also dependency. Serotonin effective in mood behaviors, the sleepiness, aggression, and also compliance. And noradrenergic system is arousal, concentration, and attention, has effects on arousal, concentration, and attention. The hyperthyroidism actually has many effects, and it has effects through noradrenergic system. However, the trials are missing for hypothyroidism, and have the depressive behaviors are there, but the pathway is not found out in hypothyroidism. You see the thyroid hormone brain map. You see in prefrontal cortex it is quite effective, and in temporal lobes, and also cerebellar area. So what does it do? And it in executive functions, the planning, the decision making, and also the behavior. In our behaviors, it is important, and the temporal space is also important. Thyroid has some negative effects on our memory. So regarding the memory, this is the most active area in the cerebral area. For the recent studies, we understand that not only in balance and coordination in cerebellum also has an effect in our memory. And we see the psychological effects as well. Cognition, what does cognition stand for us? Cognition is the area of many things: attention, focus, flexibility, memory, speed, and also the creativity. All of this actually, it is the high cortical structure. The cognition happens. What is the cognition and thyroid relation? Since 1960, as Charla pointed out, and unfortunately this happened in there is a 10-year of gap. Iodine and hypothyroidism deficiency could be the main cognition marker, and therefore iodine replacement treatment and hypothyroidism. For hypothyroidism, there have been screening tests for the infants and newborns, and the other factors in cognition, but the stress in prenatal period, and also hypothyroidism, and also the stress infections exposed to child, and also the monas structure has an effect on the intellectual structure of the infant. The thyroid hormones, as known, is important for the signalization and the brain development and the cortical structuring. It has a guiding effect. With the thyroid hormones, there is a reelin hormone, both actually valid for glutamatergic system and cholinergic system, and the glutamatergic system is for our cognitive functions. These are both important. The thyroid hormone, as I pointed out, in temporal, parietal, and hypothalamus limbic system, it affects our memory and also synaptic plasticity. And in the thyroid hormone law of pregnancy, if the thyroid hormone, if it is low in the pregnancies, the autism, children with autism risk increases. But the trials that I have read are a lot of cross-sectional, so the trials ended with there's a room for further trials. In hypothyroidism, in endocrine, we see it commonly, and as it's the case in autoimmune diseases, it is higher in women. The clinical doubt is a lot because the patients have same complaints when they refer to us. In cerebronergic and cholinergic system, because of the deficiency, fatigue syndrome, and with the depression, they refer to us. So we stigmatize the patients actually as the neurologist. Actually, we see it as a depressive or a patient with a high anxiety level, and the primary hypothyroidism is the most common reason. The primary reasons, the gland deficiency, and secondary reasons, the effects in hypothalamus, and the clinical findings are endocrine is an important gland, and it causes overall effect on the body, and with the neurocognitive effects. There is this clinical presentation. So what are the effects on central nerve system? As prefrontal cortex is affected, there is a decrease in concentration, and there is a decrease in attention. There are some depressive findings, and also reversible, it's most common reason for irreversible dementia, and it causes apathy because of the prefrontal involvement and the mental slowdown, and also the sleepiness. The psychological tests are conducted where I am. The neuropsychology actually is a multidisciplinary discipline. The brain surgeons for neurologists. It is an important guiding factor. We can see whether it's a psychiatric the presentation, or is it because of the neurodegenerative diseases. We can see whether there is this dementia table, or Korsakoff syndrome, or B12 deficiency, or could it be a tumor or a traumatic brain injury. There is a simulation, whether the patient has simulation or has a real complaint. So we used to differentiate it for the follow-up of the patient and rehabilitation of the patient. It's a very important guiding factor. The neurolog and the psychiatric, knowing the neuroanatomy, and also the clinic it has to be with the clinical neuropsychologist. It's more functional. I definitely recommend this to you. It's an important evaluation. So what do we look at in neuropsychological test? We make a cognitive evaluation, and also we make a psychological evaluation based on the state of this. If there's we check a back depression, and if we are thinking of a dementia, we give the dementia depression scales. And cognitively, what do we do? In terms of learning and memory, there's a 5 memory scale. All these tests. There is a battery that we use in Turkey. We don't apply this to all the patients, but it depends on the sociological status of the patient and the cognition level. The tests are conducted. The patient has to be awake and has to be cooperative and has to keep its attention span. In terms of learning and memory, we have a baseline memory scale, and we tell 15 words to a patient, and we want the patient to repeat this, and we can say this 6 times, and we look at how many of the words are coming back from the patient. For concentration, for attention, there are some number tests. There are some arithmetic calculations they're made by the patient, and in 1 minute, let's say we ask for the patient to come up with the names of animals, or the animals starting with K, for example. Sometimes there could be a performance anxiety. In order to decrease this, we actually are very calm, and we are talking in a very calm state. In perseverations, in 1 minute, we check how many animals the patient can come up with, if there are gaps or not. Of course, quantitatively, we make the evaluation, and we compare with the other standards with the same level of education. How many animals the patient counted, or whether there's a repetition in the animal names, or is there any problem in the names. So we check whether they're the same animals, and we check whether there's any pauses or is there any flexibility in the patient in category change alteration? If we like strip test, if in a cognitive patient with a cognitive failure, we see the patient and their academic qualification. We read the colors, and we want him to patient evaluate the different names in the patient. It can be the strip test can be guiding for us for the patients with high level of education and planning. If there is a voucher, sometimes I do some. Actually, I want the patient to do so because it's an effect of planning. Because most of the patients are literate patients, we check the planning is very important for him to put the 10. We want is the 11 to 10. We want the patient to sit at the 11 and 10. And in the we see whether the patient can see this. If there's an involvement in the right hand side, he can put it, and he cannot find the 11 because he can't see the left side. And we make the diagnostic aphasia evaluation if there's a story with visuals, and we want the patient to express this to us. And in our aphasia involvement, in primary aphasia, there could be involvement in demence. And sometimes and if there's a depression, there could be some decrease in the mood, and there's abstract thinking test. I like it. The mini-mental test is not enough for the patients in high ages. I don't recommend this. Mini-mental is 30 as a score. However, the patient has a very good cognitive. Even if the half of the cognition is gone, the mini-mental can be 30. If there is middle dementia, when you see the proverb, you see that the abstract thinking is deteriorated, and the patient in concrete thinking. For example, for a certain proverb in Turkish, the patients actually go into the concrete thinking. And in arithmetic evaluation, we check the patient, and actually I'm living in a place where there are religious people. I always ask the evening prayers, because this 4 plus 4 is an important, and plus 2 and plus 3 is an important counting, because the patient is doing this, and if the patient it's a ritual, and actually the 3 plus 2, it's the actually evening prayers. The other one is the late evening prayers. So one of the patient asked, why did you take me to a Hoca or a doctor? I think this test are inevitable. For example, I'm living in Rize. The person has to know the name of the president. If the person does not know it, it's an important evaluation. And in attention test, we give some letters to the patient. Actually, we give some numbers as well, and we see the executive planning, whether there is a marking in order, and in complicated perceptual functions, there is a Wisconsin storying test. we use this to see whether the patient actually is experiencing depression, if there is a depression or is there any neurodegenerative disease. So in this test, there could be a loss of flexibility, or there could be repetition of the same cases. We give the cards in 4 different colors, and we want the patient to make changes. We have a table in our hand, and every 10 changes. It's actually a complicated test. I need to confess this. And in every 10 cards, we guide the patient, and the patient tries to merge it, and we use in visual spatial sphere we use. Can you please wrap up, Tuğba? Here the patient, we see whether he is able to draw the shapes that we give, and we also make a visual memory test. We show the card 1, and we want the patient to redraw this. There is structuring, and also in terms of visual memory, it is important. In the proxy, it's for if when you have good sensory skills, there could be loss of some movements, especially in Parkinson's diseases and types of dementia. This can happen if we ask the patient to act like brushing his teeth. It is like he's not holding a toothbrush, but he's using it. Or we want we give him a letter to put in an envelope, and the patient is not able to do so. And in proxy, it seems that there is an involvement in Hashimoto. And there could be Hashimoto encephalopathia. This is very rare, and it goes with relapses. The thyroid hormones are normal. However, anti-TPO-AB could be elevated. It has many psychiatric effects. The movement disorder, cerebral dysfunction, encephalopathia, myxedema, edema. It causes a common death. There isn't any cognitive evaluation of the patient. There's a global involvement, and the cooperation of the patient is low. In congenital hyperthyroidism, with the neuropsychological evaluations, we see that the attention is distorted, the verbal memory is involved, and in motor skills there is a loss, and visual spatial functions there is an involvement, and there is a decrease in the intelligence level, and also in constructional skills there is a decrease, and complex problem-solving skills are affected. The tactile perceptions, perception is also involved. In hyperthyroid and the dementia, we see the in neuropsychiatric clinics, we have thyroid screening tests, and we have it causes a distortion in mental capacity, and in Alzheimer's disease, primarily the distant memory is reserved, and there is an effect in the short-term memory. The recording skill is distorted. The diagnosis and treatment actually reverse the disease. In subclinical hyperthyroidism, it is not clinically understood yet, and the working memory and the long-term memory. The patient is affected by the emotional statuses and also recording of what the patient is experiencing, and it is affected in the retrieval. And it's important for high intellectual area, and subclinical hypothyroid is affected and hyperthyroid is there. Graves' disease is the most common reason, and the clinical findings because of the systemic effects. Neuroadrenergic system is involved as well. So what are the neuropsychological effects? Mood instabilization, cognitive involvement, mania, psychosis, anxiety, and also memory and attention problems. As the stimuli in prefrontal cortex is increased, the reaction times is very short because the patient gets the answer right away, but this is a disadvantage. And there is disruptivity in the patient, and also hypersensitivity to sounds, and also mood depression. And the patients come to us with depression talking, and there could be, if thyroid is values are very high, there could be thyroid crisis, fever, delirium, and psychotic episodes, and there's an involvement in cognition, loss of orientation and concentration, hyper alert presentation, visual motor follow-up skills are distorted, and there is a mixed edema madness. There is a progressive anxiety, generalized agitation, and there is a progressive disorientation and a global disruption. How can I stop you, Tuğba? Hyperthyroid in executive planning, there is a disadvantage in decision making, concentration loss, planning, and also executive functions. There is a loss and loss in creativity. Strip test is very important to us. The reaction time is short, but there's skill of knowing is low, and the learning through the repetitive experiences is low. The patient cannot retrieve it. In dopaminergic systems, there is a loss there, as the limbic and frontal system are evolved. What I can tell you is that filter your drinking water. Make thyroid screening, and if necessary, selenium, vitamin D, vitamin E, and zinc and magnesium can be very beneficial in the patients, and it increases the cognition. And thank you very much for your kind attention. This is Pokuch Valley.